So why don't we go ahead and get started? I'm sure people will be trickling in, but I also know that we're on kind of a tight schedule. So what I'll do is ask you you can share your screen from the share screen down below. You have up to 5 minutes to speak, and then 3 minutes for questions. I will let you know when your 5 minutes are there. So try to wrap up then so that there's a couple of minutes for questions, and we will try to get through this. So I think first up, Matteo, take it away.
Yes, hi. So let me try to share my screen. Hopefully everything will be fine. Okay, does everybody see?
Excellent, perfect.
Yeah, this is the most seamless I've done so far. So today I'm going to talk to you a little bit about a study we've done in the context of COVID-19 healthcare workers. Before I start, I want to just give you some disclosures. This work has been supported by a KL2 award and also by Talkspace, who also shared the data. I have a research agreement with them about some of the machine learning findings I'll present to you today. I want to start first with a little bit of background. Like, I think it's in our collective memory at this point what healthcare workers had to endure during COVID-19. I'm thinking in particular like exaggerated amount of work, very poor equipment, a lot of stressors, the fear of infecting family. They went beyond what will normally be their duties. What maybe some people are not as much aware of is that even at baseline, healthcare workers suffer from an exorbitant amount of like psychopathology levels. Particularly, they have more than like the normal population. They suffer from anxiety symptoms, depressive symptoms, and in particular burnout. Some prevalence are up to 50% of the healthcare worker population, which includes nurses and doctors, suffer from burnout, with some estimate they give even to 80%. And you would imagine, like, why doesn't a healthcare worker who works in a medical field doesn't get treatment since they are, they're health literate? Well, there's some difficulties in terms of the fact that they don't have traditional work hours. There's some difficulties having schedule that will work with normal psychotherapy, and also general like a lack of time, which inevitably create barriers that are specific to this population in getting the mental treatment they will need. A silver line of COVID that fortunately has been echoing through this conference, as we mentioned many times, is the fact that digital health technologies and delivery methods has been emerging much more frequently thanks to COVID. And one of the solutions I'm going to present to you today has to do with what is called asynchronous two-way messaging, which is like a fancy word to saying basically that therapy is delivered asynchronously, so not in direct time between a therapist and a patient. In this case, the amount is like 5 times a week. I think 2 3 messages minimum per day. So kind of like a lower intensity, but longer in the time scale intervention, which of course, allows for people who undergo it to talk and have treatment during times when they're available. And this asynchronous component can work very well for the needs of healthcare workers. Another thing that what also captured my interest and why I started doing this work in the field of digital health is the fact that since you collect all this therapy from a digital framework, you're getting all the data. And if it's a messaging therapy, this means that you have all transcript of all therapy conversation between patients and therapists available. And the good thing is that this allows us to have like a national representative scale, the possibility to have transcripts of thousands, even millions in some cases, patient and therapist diets that you can use to study the therapeutic process. And the way we can do this to use text as data is this kind of analysis called natural language processing, which has a lot of my interest. So I'm going to present you very briefly the study in terms of what are the overall characteristics of the sample we studied. These are 820 healthcare workers. These were people that were able to access messaging therapy through Talkspace from March to July 2020. This was given to them for free because it's part of like an initiative. Most of these healthcare workers had a primary diagnosis given by a licensed therapist of anxiety, adjustment, or depression. In terms of the measure that were captured, the symptoms were collected from baseline and then every 2 weeks, which PHQ-9 for depression, JD for anxiety, so pretty normal self-report scales. What's interesting is that, again, for all these 820 healthcare workers, we had available their messaging transcript with their therapist, and we analyzed the first 3 weeks so not to have interference with treatment effects. And then we had also, since we were wondering what would be the difference between healthcare workers and non-healthcare workers, we matched them with 809 non-healthcare workers that were going through messaging therapy at the same time with similar diagnoses and demographics. So we wanted to look at 3 things. The first thing is just to have an observational sense. So this is not a control group, this is not an RCT, just to have a sense of like what were symptoms over time during the course of this treatment. What I was interested about also was the fact through NLP as a way to specifically topic modeling to analyze what kind of topics these healthcare workers were talking with their therapists during these 3 weeks of therapy at the beginning of COVID. And also we wanted to have a check if this was the same that non-healthcare worker topics had. Then the second step we did was to associate these topics with their symptomatology to see if we could find some linguistic markers. So people who have certain symptoms, do they tend to talk about certain things or not? So these are the findings very briefly. These are like the symptom measures of PHQ and JD9 over 12 weeks of treatment. The remission rate that we calculated is 56%. It's kind of consistent with some of the other discussion we were hearing across these other days. So good results. What interests me again is to look at beyond this number, because this will be able to do normal therapy. So what were they were talking about, especially in these first 3 weeks that you see here? And in terms of, we identified 30 topics to talk about that they spoke with their therapist, and 5 of them had to do with healthcare work. I'll be happy to answer more later, but for brevity, I'm going to go forward. While instead the controls only had 1 topic that was associated with healthcare work in general. So it was 5 versus 1. And what's interesting is that when we do like a GLM to see again, if you talk about this topic, what is your likelihood to have symptomatology? And what we could find in healthcare workers that beyond things that will normally be expected to be associated with depression and anxiety, specifically talking about depression, feeling sad, having problems leading panic attack, a clear association emerged between talking about hospital and ICU, the hospital unit, and having high anxiety and high depression symptoms. And interesting enough, when you do the same kind of analysis within control, again, non-healthcare workers that I'll show you, you can see there are similar association in terms of general topic about anxiety, sadness, fear, but not about their topic about healthcare. So even during COVID, even when like healthcare was such an important topic, this association that did not emerge. So to summarize the findings that I show you, basically we could see some observational improvement in terms of symptoms over time. Definitely further studies are needed in RCT. What's interesting is that healthcare workers expressed numerous concerns in terms of healthcare related topics, not as much in the controls. And some of these topics were specifically associated with higher anxiety and depression, which shows the feasibility of using NLP to assess transcript automatically to have passive markers of psychological symptoms. Excuse me. Just before I go, I just want to thank very quickly. This is a multi-site effort, particularly the people at NYU that are working with me, also the Precision Tech Behavioral Initiative, particularly Emily, who's done an amazing work with some of these analyses, and also our collaborator at Talkspace. And I'll be happy to answer any question. Thank you.
Okay, we ran a little bit over here. So if there's a quick question, we have time. Otherwise, I think probably better to, why don't we go ahead and move on, because just so we are sure to have time. So Kera, I think you're presenting for Debra Kaysen.
Yeah, I am. Thank you, everyone. Can you see my screen?
Yes.
Perfect, great. Hi, everyone. My name's Kera Mallard-Swanson, and I'm here to tell you about Pause a Moment, or PAM for short. PAM is a free confidential application for healthcare workers who experience mental health symptoms from COVID-19 or who wish to build resilience and improve self-care. PAM was designed by a team of psychologists and experts in the digital mental health field at Stanford University. This project was spearheaded by Dr. Debra Kaysen and Dr. Shannon Wiltsey-Stirman and was funded by the Jansey and Huang Foundation. Before we begin, I do want to thank the healthcare workers that have helped us develop PAM. The COVID-19 pandemic has led to unprecedented levels of stress among the healthcare workforce. Depression, anxiety, and PTSD symptoms have become more common, especially among nurses, women, other frontline workers, and workers experiencing physical symptoms. Although it's expected that many of these healthcare workers will improve on their own, a subset of these affected will develop chronic mental health symptoms. Consequences of the COVID-19 pandemic on healthcare workers can culminate in a plethora of mental health symptoms, such as feelings of exhaustion or distress, depression, anxiety, and insomnia. PAM is designed to be a free online adaptive web-based intervention that provides evidence-based mental health tools tailored for healthcare workers. These tools are derived from evidence-based strategies proven to reduce symptoms of PTSD, depression, anxiety, stress, burnout, and prolonged grief, such as cognitive behavioral therapy. PAM is tailored to the consumer, is interactive, and assists in building skills in the moment and for long-term resilience. The app was developed with input from healthcare workers from a variety of fields, including nurses, doctors, medical scribes, and technicians. Consumers are able to tailor their experience based on their current mood, symptom profile, or any specific concerns they might be experiencing in that moment. These tools are focused on targeting depression, anxiety, PTSD, and stress. The types of tools the program has include cognitive restructuring, behavioral activation, mindfulness, and problem solving, among others, and includes both brief tools and longer, more in-depth ones. We included both tools that could be used in the moment and others that might take a little bit longer to have an effect, but would be more likely to have lasting change. Skills can be repeated multiple times, and these are a few of the tools that we have currently available. We will be releasing about 5 more tools in the next coming months as well. Consumers are predominantly female in their late 30s. They're predominantly white, but with a fairly good inclusion of Asian American and Hispanic Latinx individuals. We have a fairly wide range of healthcare professionals. Not surprisingly, nursing was the most common profession, but we also have a number of non-healthcare professionals. The easier, more brief skills are the ones that are frequently favored, but are not the ones that we're seeing consumers return to, such as problem solving and cognitive restructuring activities. Preliminary results indicate good outreach and engagement with PAM for those experiencing mild to moderate mental health symptoms, in addition to building and practicing skills for resilience and feelings of support. We're excited to present PAM to you and encourage you guys to check us out.
Okay, thank you, Kara. Any questions? I guess one question I have, was this rolled out primarily at Stanford or across multiple?
Yeah, so initially we rolled it out in February 2022 within Stanford, but we are also talking with a bunch of different healthcare systems across the nation to roll it out within their organizations.
And so you said that it sounded like some of the tools were, can you say again, which tools had lower usage and which had higher?
Yeah, so the tools that were most frequently used were the quick, more like grounding in the moment type of tools, but we are seeing a higher return rate on the tools that have lasting effects. So more of the cognitive restructuring type of tools. So even though those we're not seeing as much of, we are seeing more people coming back and returning to those within their individual profiles.
All right. Any other questions?
I see one about the funding. So the funding did come from Stanford, from the Jensen and Lori Huang Foundation. We are currently exploring other avenues of getting more research funding. So we are excited for the sustainability of this project and are also looking for new funding opportunities.
Others? All right. Another question. I'm wondering what are some key factors of the app contributing to users' engagement and adherence?
So at this moment, we are not 100% sure. We are going to be doing some preliminary interviews and getting some more data collected around the contributing factors to engagement. At this point, we know that these quick, useful tools that people are able to use in the moment when they are experiencing distress are extremely helpful. And so with the next round of funding, we will start exploring more around what are these key components that are bringing people back and continuing to use the product.
All right. Well, thank you. And why don't we move now to Clarisa, talking about accessibility and online help-seeking behavior in youth during COVID-19.
Can you see my screen? Okay. So hi everyone, my name is Clarisa. I'm a graduate student at Northwestern, and today I'm going to be presenting on accessibility and online help-seeking behavior in youth during COVID-19. So a little bit of background on the topic. With the spread of COVID-19, adolescents are spending more time to fulfill their mental and physical health needs online, and online resources provide additional platforms while overcoming barriers of traditional help seeking, such as stigma surrounding mental health seeking, time, cost, and lack of access to mental health services. However, accessibility is a major determinant in fulfillment of online help seeking, and it is estimated that 93% of youth are already online. However, accessibility is much more complex than that. Accessibility includes considerations around inconsistent access, such as shared devices with family, limited connectivity, and conditional restraints specific to youth, such as device taken away as punishment and school restrictions. Therefore, this is the first study to take a granular look at accessibility of online online resources in youth online help seeking. So our first aim of the study is to examine what type of online resources youth are using for mental and physical health concerns. So our study is a cross-sectional survey study with 275 adolescents from across the United States. We asked demographic questions such as race, ethnicity, gender, and socioeconomic status. And we use a validated proxy for socioeconomic status in adolescents, which asks teens their eligibility for free and reduced lunch. Teens who qualify for free or reduced lunch are 130% below poverty line, according to the USDA in the United States. And we also asked about perceived accessibility, such as percentage of sole access to devices connected to the internet, and also types of resources used, which are asked in a free response type question. So the participants' demographic of our sample, we prioritize racial, gender, socioeconomic status, and geographical diversity in our sample. The pie chart illustrates the racial diversity in our sample, and our sample is representative of the teen population in the US to an extent. The age we recruited were 13 to 17 years old with an average of 15.16. Gender identity of our sample, 50% identified as male, 48% identified as female, and 2% identified as non-binary. And according to the proxy we used to measure socioeconomic status, 47% of our sample identified as low socioeconomic status. And we have also geographical diversity because we recruited adolescents throughout the United States. So the results, we asked two free response questions where we coded type of online resources categories, and responses were coded using content analysis. The top three categories that youth would go online is online search engines such as Google and Wikipedia, health websites such as WebMD, and social media such as Instagram and TikTok. However, we do notice that there is a huge percentage of adolescents who don't know where to go for their mental health concerns online. The findings for physical health is illustrated also in this pie chart, except we noticed that participants who does not know where to go for physical health concern is much less here compared to for the mental health results. And instead, participants here resorted to more health websites such as WebMD, much more when seeking for physical health resources compared to mental health resources. And for the second aim, Given the complexity of accessibility, especially among those with different SES, we are interested in examining if there is a difference in accessibility of online help seeking based on SES. And we found that teenagers with lower SES have significantly lower sole access to devices connected to the internet compared to teens with higher SES. And to summarize, majority of adolescents reported having frequent access to technology devices and were able to access online platforms to access information about physical and mental health resources. However, concerns do remain about accessibility of these online resources, particularly for teens with lower socioeconomic status. And findings should be taken in light of methodology limitations, since it was an online survey on Qualtrics. Our results do not generalize to adolescents who have no access to devices and internet, which is an important future direction that requires non-digital methodology to examine the differences. And future directions should also consider how online health information can be made more accessible and accurate to this vulnerable population. And also, additionally, although it might seem like youth are very adept at using internet, there are still disparities in digital literacy similar to accessibility. So future research should also investigate how online help seeking trends differ by digital literacy in youth. And also future investigation should also examine how to increase knowledge of and use of mental health resources, since a huge proportion of youth doesn't know where to go to seek for mental health resources. Thank you.
Well, thank you. Any questions? We have a couple of minutes here. I mean, one thing that I was wondering is, do you see, you had a lot of kids that don't know where to go. Did you see that at all related to the age? Oh, I'm sorry. I see a couple of hands up. So, Colleen, did you have a?
I was clapping.
Oh, you were clapping? All right.
Since you're in the middle of a question, please continue.
So I was just wondering whether there was an age, if you know whether that's related to age, that younger people.
We actually didn't examine if it was because of age, but I thought it was interesting that more youth know where to go when seeking physical health resources compared to mental health resources. And the difference is almost half of the youth know where to go between like physical health compared to mental health, which is interesting to see.
Mm-hmm. All right, any other questions? Then if there aren't, why don't we move on? Shireen, we're talking about dialectical therapy.
Yes.
Dialectical behavioral therapy.
Let's see if I'm as facile as everybody else is with this. Okay. Can you see just the presentation piece? Thank you.
Yeah.
For the thumbs up. Okay. So I'm going to be presenting on our study in which we developed dialectical behavior therapy skills videos and delivered them via smartphones. And we'll present on the feasibility, acceptability, and some outcomes. So this was a study, let's see. This was a study done with college students during the fall of 2020. And I think we tend to think in our field about college students as being samples of convenience, but actually there's more and more data to indicate that college students have significant mental health problems on par with the rest of the population. 1 in 3 college students have significant problems with anxiety, depression, or suicidal behavior. Suicide is the second leading cause of death of this group. And also to note that many psychological disorders have onset during this critical developmental period, and that there's a lot of stressors in the lives of college students, including major life transitions, as well as increasing stress over the course of the semester. And this will be an important thing for us to bear in mind when I show the results. And then, of course, in the fall of 2020, there was a lot going on. COVID-19 was happening, and at Rutgers, where this study took place, the semester was entirely remote. And students were not even living on campus. There were other stressors happening at that time, including the presidential election in the US and ongoing racial reckoning stressors. So all in all, a time where we might need to, or we had to think about what are interventions that might be useful for this time and this population. So I won't do a lot of explanation about dialectical behavior therapy or DBT, but of course, many of you know that DBT is a comprehensive treatment package, and skills training is one component of it. There have been a number of studies now that have looked at just the skills training component of DBT and has found DBT skills to be effective at increasing coping. And there's a lot of limitations to delivering DBT in its traditional format, including DBT skills only. In college counseling centers, students may not necessarily approach the counseling center for help or seek out therapy. College counseling centers often have limited resources. The average number of sessions for students is, or maximum number of sessions is 5 or 6. And the time-intensive nature of DBT limits its scalability. So we also need to think about what are ways in which we can make DBT more accessible to individuals who need it. So this study was to look at the feasibility, acceptability, and initial efficacy of a 14-day intervention involving daily DBT skills videos. The videos were all about 5 minutes long. Actually, the average video length was 4 minutes. These are some screenshots from the videos. And we had a couple of hypotheses that our first was that we thought that the videos would be likable, relevant, and be associated with reduced negative affect. And our second hypothesis was that compared to controls, participants receiving the videos would have decreased distress over the course of the study. This was our design and our participants. So this was conducted at Rutgers University here in New Jersey. That's our demographics. The racial and ethnic breakdown matches the broader population of Rutgers. The design was that we would have a 2-week assessment period. This was EMA assessments 4 times a day. At the end of the second week, participants would be randomized at a 2/3, 1/3 ratio to either receive the intervention or to not receive the intervention and just continue to do the EMA assessment. And then there was a 2-week post-intervention period. I realized I did not check the time when I started talking, so I'm just going to keep going, but you yank me.
You got about 30 seconds. But
I should have checked the time. Okay, results. So in general, the study was found to be feasible and acceptable. We had moderate to high assessment compliance, moderate to high ratings on videos. In terms of engagement, we found that 84% of the sample watched more than 1 video, and about 1/4 of the population sample watched all 14. We showed that after watching the videos, there was a significant increase in positive affect and a significant decrease in negative affect. And then we also found, interestingly, an interaction between time and condition on this variable of tolerance of emotions. And what we found was that controls rated their own emotional experiences as more unbearable as the study ended. So basically, they went up in terms of a word we made up, unbearability of emotions, whereas those who were in the intervention condition actually stayed the same. So this was over the context of a semester when we might think that there were more stressors as the semester went on. The folks who received the videos seemed to perhaps, do better in this sense than the ones who did not receive the videos, but how that was reflected was that they actually looked like they were staying the same. So this was a light touch intervention, but seems to have a significant impact on momentary affect and tolerance of emotions over time. Videos are easily disseminated, and our future research is looking at videos. as a first step, low dose intervention. Sorry, there's a.
Can I ask people to mute who aren't speaking? Thanks.
And then just lastly, these are some acknowledgements and resources. The paper is in Press and Behavior Research and Therapy, and the videos are available publicly on our YouTube site.
Thank you, Shireen. Any questions? Okay, I do see those are clapping hands. And so here, were students encouraged to practice skills learned in the videos?
They were not actively encouraged. When we dropped a video every day, once a day for those 14 weeks. So they got a notification when the video was available. And at the end of the video, they were told that the video would be available for them to access as many times as they want going forward.
Okay, and then another question, really impressive work. I'm curious, what are some of the important design rationale when translating DBT skills into relatable, accessible video content?
Well, I don't know if I had a strong rationale or system. I really, I've been teaching DBT for over 20 years. And so I was really focused on what are the critical elements, but also staying really true and faithful to the manual. And then we also, just in terms of the relatable video content, you saw those figures that we came up with for these videos. We did this study very quickly. We had, a couple months to develop all these animated videos and put them into this program. If we had more time, we would have done more iterative development and more back and forth with stakeholders. We're proposing to do that in a future study, but we really wanted to focus on these videos as being as inclusive and accessible as possible to anybody. And that's where we landed on these figures. But I'm looking forward to getting more information from stakeholders as to what they like and dislike about these videos so that we can continue to improve them.
All right. Thank you so much for a terrific talk. Now, Jennifer, are you ready? Great.
I think you're muted,
I
Jennifer.
think you're muted.
Yes, okay, sorry. So I'll be talking about engagement in a primary care clinic, about people using e-mental health tools. So as you know, e-mental health tools such as online programs or phone apps, they have become an important part of treatment for depression, anxiety, or other mental illnesses. However, their uptake and use remain low despite ongoing effort to provide coaching to patients and support. So we know primary care clinics are often the first level of contact for mental health care. We decided to use a primary care clinic existing program, which is called the Collaborative Care Program in an underserved area. And what the Collaborative Care Program means is, for those who are not familiar with this model, it's been around for more than 20 years. And it's a program where it's a model where we have a social worker who is at the center of treatment for patients in a primary care clinic. So primary care doctors refer patients with mental illness to a social worker. Sometimes a care manager also could be a nurse. So patients are referred to a care manager who does an initial assessment and then meet on a regular basis with a psychiatrist for an hour or two every week, presenting new patients or follow-ups on patients that were already enrolled. And psychiatrists provide treatment recommendations, put a brief note in the medical records, and PCP, usually primary care doctors, are the one prescribing medications. So psychiatrists are just consultant, and psychiatrists discuss, they make the decision based on their discussion with those social workers who will contact patients, share the treatment plan, and also be the liaison between the psychiatrist and patients, or primary care doctor and patients. So this is the first study looking at using the care manager from a collaborative care program for mental health, digital health engagement. And one thing I should add, the care manager, and usually they will check on a regular basis with patients to monitor for medications, side effects, response, and also do some brief psychotherapy. So what we did was, this was a non-randomized preferred assignment study, and we let patients pick and choose between 3 digital health programs, and that was a CBT phone app, a CBT online program, and a general website that University of Michigan developed with some coping skills training. And so patients had to choose between all those 3. And I should say ModKit and ModGym, those are well-validated tools that were already studied by many times, and they show to be effective. So the primary goal here was to see how patients engage and why they engage. So patients were asked to use those tools 3 times a week for 15 minutes at a time, not 5, but 15 minutes at a time for 6 weeks. Then the social worker this was combined with a weekly call from the social worker. And keep in mind, the social worker already placing those calls. So this is part of the social worker. This is part of the model where you have a social worker checking in regularly for medication monitoring and brief psychotherapy with patients. So what we did was to list a few items that the social worker can use as a coaching, some sort of low intensity coaching, to use the app and checking and see how patients are doing, see what works, see what doesn't work, and also validate the effort they're putting in. So social workers usually within that model will call patients once a week, once every other week. Some places, depending on how big is the caseload, social workers may call patients maybe once every 3 weeks. But for the purpose of this study, and also in our clinic, the clinic we use, the social worker was calling patient mostly once a week. So we use that as part of our method. And after those 6 weeks where the social worker checked in with patients, we wanted to see if patients would continue to use the app for another 4 weeks, so without any coaching. So in total, this was a small sample of 32 participants. Most of them were women and non-Hispanic Caucasian, which reflect the area where the clinic is placed. And the mean age was 41 years old and 41.8. And the PHQ-9, most of those patients had moderate to moderately severe depression, which is something that initially we were a little concerned, since we know there is a correlation between severity of depressive symptoms and engagement in mental health tools, digital health. And we have 19% of patients had severe depression. So in terms of results, patients, sorry?
You're a little over 5 minutes, so just
okay. I'm wrapping up right now. Okay. So patients choose those 3 tools. ModGym was the first choice. And we had actually patients who were using the tool. They were asked to use it 3 times a week. They use it 3.3 times a week for 6 weeks. And half of the time they use it for 11 to 20 minutes. The expectation was 15 minutes. And 78% continue to use the tool without any coaching for at least 4 weeks. And actually, most of them started noticing an extreme satisfaction with the tool as they use it. So when we look at the results, we realize that what exactly made people pick and stay with the tool they use was initially their personal choice. The fact that we didn't assign the tool, but we let them pick the tool they want. And keep in mind, they were picking those tools based on how they were organized, how easy they were to use, how they thought it could be helpful, and also privacy policies. So we actually give them a summary of each tool at the beginning. And also realize that having the care manager, the social worker, was really helpful. Barrier, as you know, lack of time, severity of depressive symptoms, and uncertainty about whether or not this tool will really help were the barrier to uptake. Thank you.
Thank you. Any questions? No questions? So I think that's really interesting that you you know that patient choice you feel really makes a difference. Did you see, it sounded like you had you looked at if I saw that correctly, that the use was across all of the tools. And I'm wondering, like, did you see that also for the informational pages? Because that seems like it would be harder to engage with consistently and repeatedly.
Was the engagement the same for all?
Oh yeah, or was
all
it the
three?
same for all three?
It was higher for both the CBT phone app and the CBT program that we had, more than the University of Michigan general, coping skill tool that we had on the website. Yeah,
that makes sense. Any other questions? All right, thank you, Jennifer.
Thank you.
Marvin, stay well at home.
Yeah, let's see if I can keep the trend of not struggling with technology. All right, let me just move some screens around so I can see what I'm talking about. Okay, well, thank you all for being here, and great work to all the presenters so far, and really interesting stuff, exciting stuff that you're doing. Let me double check. You can see just the regular screen, right? Like not the notes section. Okay, cool. Thumbs up. I like that. Feedback's really helpful. So Marvin Arevalo, I am a postdoctoral scholar at the School of Social Welfare at UC Berkeley. I work under my mentor, Dr. Adrian Aguilera, who has a digital health equity and access lab, and who has a long, prolific career in digital health interventions, digital mental health interventions, I should say. So I'm not gonna sort of go into like a lot of the theory, because I'm sure a lot of you here have a psychology background or are familiar with sort of CBT and all the fun theories that we have in psychology for mental health treatment. But let me tell you quickly about Stay Well at Home. So Stay Well at Home, it's a fully remote text-based intervention designed to support mental health during social distancing and the COVID-19 pandemic. We developed a bank of messages, tip messages based on CBT that included behavioral activation tips, or also just general psychoeducation. And then participants who sign up to receive the Stay Well at Home program receive 2 daily messages during a 60-day period. One of the messages had like a general tip, right, belonging to those 2 buckets that I described earlier. And then 3 hours after the tip message, we asked them to rate their mood on a scale of 1 to 9 as a way of collecting data based on the messages that were sent. So really quickly, we collected data from April to December of 2020. Like I mentioned, 60-day text messaging program. And our main interest and outcomes were to see if there was reductions in depression scores and anxiety scores, so PHQ-8, GAD-2. We recruited mostly through online methods, so Facebook primarily, Craigslist, some university listservs, and it was sort of national. We had the most participants from California, but we also saw a large number of users from Texas, Florida, and I believe the other one was New York. And it says, the talk of my presentation is with diverse communities, because this is where this all started in the conceptualization of the study. When we developed the message banks, we were thinking about reaching a wide range of populations, including Spanish speakers. And so the team who had bicultural, bilingual researchers also developed the bank in Spanish. And then when we went to the recruitment effort, we really tried to target Facebook had this function. They got rid of it now, but they had this function where you could create personas based on target users. And so we created personas for people that would represent those most likely to belong to an underrepresented racial ethnic group or other racial minority, Spanish speakers, etc. And all our data collection took place through Qualtrics, so like a pre-intervention, post-intervention baseline, and through Dr. Aguilera's Healthy SMS system, which is it's a platform that allows us to program and text messages, deliver them to the user, and collect data as well. These are some of the sample characteristics of the, I should mention, the main paper has been published in JMIR in mental health just last year. This is the paper for the entire study, which included 303 people. But I'm only going to talk a little bit about the subsample of racial ethnic minority participants today. So this is just a quick snapshot of the demographics. Predominantly women, predominantly English speakers, but we did have close to 22% of Spanish speakers that enrolled. The age average was 32 years old. And as you can see, we had a pretty good racial ethnic demographic breakdown. And also, we can talk about this at length later, but we can see that most of the people actually had some college or higher, which I think it's indicative of the recruitment methods that we were using. Let's see. So the general results is we did see reductions in PHQ-8 after the 60-day interventions, close to 20% or 20% reductions, and that was significant. And then we also saw some reductions in GAD2 scores. We also found that on average, users responded frequently to the text messages that asked them to rate their mood, so 67.7%. And we collected feedback on usability, so like how easy they perceive to use the program. And there's a pretty well-validated measure, the system usability scale, and we got, it should not be percentage, it should be 78.86 out of 100 usability. The gold standard for internet-based software, it's 80. So it's pretty close to having excellent usability among this sample. As you notice, there's only kept 99 participants in this analysis because we lost the remaining to follow-up. There was a significant differences in the terms of response rates. So those who did not complete the exit survey responded less on average than those that did complete the exit survey, but neither response rate nor usability and other demographic variables were significant predictors in the changes in these scores. So. And really quick, so participants improve in those who participate in the Stay Well program improved their depression and anxiety symptoms at the completion of the 60 days. They had high engagement with the daily mood rating check-in messages. They reported that the texting program was generally easy to use, and we think that low-intensity, scalable text-based mental health interventions can help improve outcomes among diverse communities. And yeah, thank you. I think I went a little over.
It's okay, we got a couple of minutes for questions. So if, does anybody have any? Thank you. So, I guess I'm wondering, because you're using text messaging, which is, kind of interesting because it's, entirely push. So people get the messages. What are your thoughts about the scalability of messaging interventions?
Yeah, so the reason why we chose text messages is because we think those are the most low intensity, right? Like I heard some great presentations just about like using VR and other like more advanced technology, if you will, but those are not going to be as accessible to most people. Now, like pretty much everyone has a phone, and can quickly respond to text messages. I will say one of the biggest limitations to text messages that we have is that, just like you suggested, is the push, right? Like we're sending a tip, but we don't actually know if people are engaging with that recommendation, right? We don't actually know if they're responding to the suggestion that we're giving them, or when they're responding to the suggestion, right? So those are some limitations in just the methodology that we have so far. But the sending a tip message and asking them later how they're feeling, and they just providing a rating from 1 to 9 was pretty, efficient, I would say, just for like that purpose.
You do get some data back in that, whether they're responding to the mood ratings.
Exactly, and often, we don't ask people to engage and respond back, but some people almost treat it like a chatbot. Like they'll respond to some prompts. So not from this study, but from other studies that we conducted, we found that when we send a tip message with like a question mark, a lot of users will actually engage. So for example, we might say like, what is something small that you can do to take care of yourself today? And they'll just respond to that message without being prompted, like, we don't tell them as part of the study that they're expected to respond, but they do that anyways. And so we did see, I think, on this particular study about 60% like unprompted responses from various users, and So I think that's exciting. We're going to analyze those data and move forward with some more usability and feasibility on this particular study.
Great. All right. Well, thank you, Marvin. And
Thanks.
last but not least, Colleen.
All right, I will pull up my stuff. I'm excited to be among all these great presentations. It's been fun to see all of your work. There we go. So I'm gonna start my timer. Hi, my name is Colleen Stiles-Shields. I would be remiss if I didn't start off by shouting the praises of this wonderful team you see pictured here. I also have to acknowledge funding from the Kuhn Family Foundation and the NIMH. But what I'd really like to talk to you about, I'll start by introducing myself. I'm a pediatric psychologist and a lifelong Chicagoan. And I'd like for digital mental health tools to help us reach more teens, particularly those with depression and anxiety. However, due to historical and current injustices, there are many teens who have just not been welcome and wanted at the intervention and tech design tables. And in my city of Chicago, this invitation can often be pinpointed based on where you live. So you can see right here, based on what train line you live off of, you have a lifespan varying by up to 15 years. And COVID certainly didn't help this. So you'll see here, the purple indicates physical health, brown equals mental health. You can very clearly see how things impacted Chicago's South and West Side neighborhoods. And these differences also occur on the digital divide. So the South and West Side communities are way less likely to have home broadband and internet access. So today I'm quickly providing some feedback we got from teens and caregivers from our South and West Side communities about how mHealth could better work for them, because I'd like them to be welcome and wanted to the table. So to do that, we should probably ask them how. So of note, we excitedly started this work in the spring of 2020. So what could go wrong, right? As everyone knows, a lot went wrong. But because of the pandemic, we moved everything to remote and have found out that, unsurprisingly, that's a heck of a lot easier for everyone. Parents, caregivers, teens, all preferred texting. So much easier to get parental consent for research if it's all online. This is something that every single participant told us that they'd really like us to keep moving forward. So we will. So before I dive in to show you a little bit about who we worked with, we had 7 teens work with us and 10 caregivers. Everyone identified with minoritized identities, and everyone was from our South and West Side communities in Chicago. So 6 themes emerged from qualitative data from our focus groups. And in terms of smartphones, that wound up being in terms of use of, ubiquity of, and effects of. We did not query anything specific about COVID-19, but this was happening in the context of the pandemic, because we're still in a pandemic. So certainly a lot came up and it became its own theme. Additionally, we learned about awareness of health and wellness and barriers to treatment. But to give you a little bit of a taste of some of the things we found, for mental health concerns, teens brought up primary issues with depression, stress, anxiety, and cyberbullying. And many saw the teen years as the onset of these problems. Additionally, like I said, COVID was brought up repeatedly by participants without us querying about it. And despite COVID having a lot of impact, it's also opening some doors that were previously not there. Because a lot of teachers and caregivers were connecting via remote technologies, kids were really bringing up that they're a lot more open to pediatricians, teachers, trusted adults checking in about their mood in ways they weren't open to before. In terms of barriers, mental health shame and stigma is certainly an issue. We also were really worried about service outages causing major disruptions. Most teens experienced them, but said it's not really a big deal. And finally, there were some general hesitancies about mHealth that were brought up. So for caregivers, while they were super excited about wellness apps, so things that promote sleep or exercise, they were really concerned about apps focused on mental health, creating a sense of dependency for their teens. So the line between wellness and mental health, there were very different concerns, and they just did not want mood to be tied to an app in any way. For both teens and caregivers, there were concerns expressed about data privacy and needing really clear expectations of use and function for apps. And finally, of note, for this presentation, many teens voice feelings of loneliness, especially associated with social media and general tech use. So any mHealth aimed at these teens has to not only overcome the barriers I've already mentioned, but also has to be inviting beyond the noise created by other tech tools on their phone. All right, I'm a fast talker. I made it just under the 5 minutes. That concludes my flash talk. Happy if there are any questions.
Any questions from anyone?
Yeah, I can ask a quick question. How do you understand or make sense of some of the differences in like the concerns between the caregivers and the youth regarding the use of mHealth?
It's interesting. I think the teens, were wary in the sense that they want data privacy, they want clear expectations, but a fair number of them have tried different things, like have tried Headspace. And so they were voicing a lot more concerns about just general engagement and usability and how it fits into their life. Whereas caregivers were less likely to have really experimented with the mental health part of mHealth, and really were focused on more behavioral health issues with their kids, and saw apps as a great way into that. I will say, as a contrast, they thought that mHealth was a good way into engaging their kids because they're on their phones anyway. They might feel more trusting. But the idea of dependency was just such a consistent concern across caregivers that teens never voiced. That's a really helpful thing to start thinking about when we're pitching these tools as helpful, helping folks understand that helpful doesn't mean use all the time, and really understand the clear expectations of use, and that skills are something that hopefully you learn and only need training wheels going forward, as opposed to an app controlling how you're feeling.
Yeah, thanks for that.
Yeah, so it sounds like you see that as something that just it almost sounds like among the caregivers, it's kind of an issue of digital mental health literacy that you're encountering. Yeah.
It was a fun group to work with. We've got some papers coming out of this. We learned a lot, and it was a really, really great group who I hope we can continue to engage.
Any other questions? Well, I was perhaps a little too severe on running, so we have a few minutes, and I know Matteo, we cut you a little short, and I actually had a question for you, so maybe we can just go back, because I did like your talk. I'm wondering, like, using the NLP, you were able to distinguish the kinds of things that people that your quote unquote controls versus the healthcare workers were using. What role would you see for something like NLP in text-based services like Talkspace? Where would you see this going as a tool that gets integrated into those kinds of interventions?
Thank you, David. Thank you also for healing my trauma. I was afraid I went too fast.
No, it's okay.
I think that, to give you an answer, probably the biggest metaphor I can give is the thermometer, because the idea that we know many of our patients, even if it's just a PHQ-9, which is just, like 9 items, have very hard time finishing these scales. So the adherence becomes a problem, because then all our digital health outcomes are connected to their scale. So if they're not able to finish them, we have some troubles understanding what works for whom, even in cases where this is effective. So I think that my hope for NLP is to become a way that if we can capture passive markers, we can have information about how patients are doing in a way that somehow is seamless, doesn't require attention from them. And of course, this will be only one part of what a clinician and their authority over the case is. But at least it can help provide some low-level information that can inform us where the treatment is going in a way that doesn't require any effort from the patient.
Yeah, and I kind of think it's almost like, because the symptom assessment is one thing, but another is, making sure that clinicians are paying attention to what's important to the patient. And so it's also sort of the behavioral targets that so you were identifying kind of in a sense, kind of what the concerns were of people that, clinicians may or may get or may miss. So I could see that as being a real useful tool for clinicians providing that kind of treatment.
No, definitely. And as with everything, it needs more studies, because I think on one side, we want to make sure that the clinician or the therapist have the agency over their case. On the other side, we want to see maybe this is something really effective. This is something that is important to take care of, and then can become part of the clinical routine.
Mm-hmm. All right. Any other questions for anybody on the panel? Thoughts? Reflections?
I just want to say quickly, you know, I've been attending several of these talks and connecting with other folks about the status of digital mental health and addressing health equity issues and representation. And I think this Flash Talk track was perhaps one of the first spaces when I think there's been a little more intentionality of actually centering some of this work on underrepresented communities. And it's exciting because a lot of people are doing a lot of stuff, but sometimes it's not reaching those who have been historically marginalized or underrepresented. So yeah, just wanted to acknowledge that.
Yeah, and I'm glad that you acknowledge that, because I also feel like a lot of the work that we do in digital mental health, I mean, we talk about it being an avenue to getting to underserved communities, but we end up working with communities who are already well served. And so we're really, you know, we're not doing a good enough job at harnessing the real social value, the potential social value that is, you know, that these kinds of tools have. So thanks for bringing that up. All right, well then, if there are no other questions, you know, give you 7 minutes to go, you know, before we wrap up. Do come to the last closing remarks, but I'll give you, 7 minutes back to do whatever you need to do. Thank you all for presenting. This has been a really great panel. So thank you.